diagnosis of acute abdomen, like all of these conditions would be called as acute abdomen, but then the reason why they are being discussed is that you just need to identify each one of them in a shortest possible time frame, under 1 minute. In the first one of this acute abdomen, severe abdominal pain, you are noticing that there is gas under the diaphragm. So immediately you are able to pick up this, I can call it cupola sign, I can call it, I mean there are a couple of fancy names also. One of the fancy name is mustache sign. Instead of mustache sign, I can call it cupola sign, or the traditional gas under the diaphragm. If any one of them is written, then your final diagnosis of this person would be given as pneumoperitoneum. And in one of the questions, like he did not ask like what is the diagnosis, because it is self-obvious. He said what is the cause of this presentation. So the cause of this presentation would be given as perforation peritonitis, which was written in the MCQ as hollow viscous perforation. Why this hollow viscous perforation is occurring is again because of a duodenal ulcer. You see, posterior duodenal ulcers would be having higher chances of bleeding, and anterior duodenal ulcers have a blowout happening, that is a perforation peritonitis. In fact, this has also been asked as a two-step question. He said, like, if the person, like he himself mentioned, patient was documented to be having a duodenal ulcer, he said, what will you do in this condition? So for the management purposes, obviously, we will first do an exploratory laparotomy in these patients. But after the laparotomy has been done, we need to fix that perforation that is occurred in the first part of the duodenum anteriorly. And for this, we will be putting a Graham's patch that is called as a omental patch. So Graham's patch or omental patch would be used in this condition so as to manage the patient. So there are three things I said: pneumoperitoneum caused by hollow viscous perforation, that is a duodenal ulcer that is mostly anteriorly located. As compared to posterior one, the posterior one has higher chances of bleeding, and then we'll go for exploratory laparotomy with a Graham omental patch. In the second presentation, there would be description of colicky pain. And along with colicky pain, he will also say that the person is having bilious vomiting. These two words alone are sufficient for you to work out that the acute abdomen that is occurring in the person is because of intestinal obstruction. And then when you check out, you can see multiple dilated bowel loops. You can see multiple air fluid levels in the abdomen. So these multiple air fluid levels demonstrated indicate that the person is suffering from a small bowel obstruction. Sometimes the bowel loops can be present like this also in the middle part, that is called as a step-ladder pattern. So if that is given, that is great. Otherwise, even in the image that is given, there are like large number of bowel loops of the jejunum getting dilated. So even if the step-ladder pattern is not given, it's like discrete large number of loops that are present, we will still answer it as a SBO, that is a small bowel obstruction. It can be a two-step question. He may not say why it is it small bowel obstruction? He will say why is it happening? So then if he says why, then just like superiorly I was telling you that it is hollow viscous perforation, your answer would be given as adhesions. This guy could have undergone a surgery previously, and because the guy underwent a surgery previously, there would be adhesions developing between two parts of the gut that can contribute to it, or it can be congenital bands. So adhesions or bands are the reason for development of a small bowel obstruction in a patient, where again we will have to go ahead with the like exploratory laparotomy. Additional point which I want to say for this particular condition, that is to assist you with the diagnosis, the question in the examination findings may write words like guarding, rigidity, that guarding and rigidity of the anterior abdominal wall, because like the whole abdominal muscle board like rigidity of the abdominal wall is because of the irritation of the peritoneum by the acid that is released from a perforated duodenal ulcer. So guarding and rigidity of the anterior abdominal wall, if given in a question, are more pointers in favor of that perforation peritonitis or hollow viscous perforation that I was describing. Now, if I move down, you can notice that it is the large bowel of the patient that is dilated. So the manifestations in this condition will also be, one is gross abdominal distension. This particular person presented to the hospital with gross abdominal distension with or without pain. I mean, initially they might be pain, then the pain might be disappearing in the patient also. It's just gross tympanitic note on the anterior on the whole of the abdomen. And along with this, there would be obstipation. Obstipation means that there would be inability to pass gas. There would be inability to pass flatus. One is constipation. I'm saying obstipation, inability to pass gas and flatus. And along with this, when we are doing an X-ray in the patient, we can notice these hugely, like you can see the hostrations there, right? You can see the hostrations. So therefore, since the hostrations in this case are visible, we are talking about a LBO, that is a large bowel obstruction in a patient. And well, why do you have a large bowel obstruction? Then one of the causes can be malignancy, Obviously, it could be sigmoid volvulus, it could be diverticulitis, but then first and foremost, I need to think in terms of malignancy as one of the reasons why large bowel obstruction could be occurring in a patient. Like we can see a cutoff which is present here. And then I would like to mention one more condition where that classical coffee bean, like this will also cause large bowel obstruction. The radiological finding that would be given here would be either called as a bent inner tube sign. Either the word used is coffee bean, or you might use the word bent inner tube. The basic spirit is still the same, that there is a sigmoid volvulus that is happening, that is occurring in anti-clockwise direction. Cecal volvulus occurs in clockwise. Cecum volvulus occurs clockwise, and the one that we're discussing at the moment is a sigmoid volvulus, which will be going in a, like it would be going the other way, that is anti-clockwise. So the diagnosis of this particular condition that is given would be given as sigmoid volvulus. There is one more hint that is given here, that is that very classical like bird beak defect with respect to barium enema in the patient. Like bird beak I described earlier for barium swallow, but for sigmoid volvulus this bird beak will be with respect to the barium enema. I'll just highlight it here, sigmoid volvulus. The barium enema finding in the patient is what is called as a bird beak. So earlier I was describing like bird beak with respect to a barium swallow. Let's just summarize the sigmoid volvulus: severe pain, colicky abdominal pain anyway, because initially like when it gets rotated, intestine will contract with proximal part of the intestine will contract with more force to overcome the obstruction. So initially you'll have a lot of pain, and then gradually the intestine will become paralyzed. But the message is when it rotated on its own axis, it will squeeze, like it will try to overcome the obstruction, and that's why you get a colicky pain, massive abdominal distension and obstipation. The note on the abdomen would be tympanitic. There's an empty rectum on a rectal examination. Sometimes visible peristalsis may be seen. Traditionally, we read about visible peristalsis with that congenital hypertrophic pyloric stenosis, but that will also come up in the discussion. But at the moment, the visible peristalsis is being discussed for like a patient where the distal part of the bowel tend to rotate on one side. Then if the patient comes late, there would be dehydration, tachycardia, and sometimes because of compromise of the blood supply, even peritonitis, guarding shock could occur in this patient. That's because that the intestine simply gave away because the blood supply got compromised. If he says what is the investigational choice for sigmoid volvulus, then don't answer barium enema, don't answer X-ray abdomen. Then your answer in those circumstances, if he specifically says what is the investigational choice for sigmoid volvulus, would be given as CT abdomen, where you get a whirl sign. Whirl sign means that rotated abdomen and the twisted mesenteric vessels can be seen. For management, it can be endoscopic detorsion with sigmoidoscopy. Sometimes if there is gonna be like this is the initial step, endoscopic detortion. Then we go in for a sigmoid colectomy with a primary anastomosis, and in unstable patients it is Hartmann procedure. Like he said, what is the earliest management? Then it is an endoscopic detortion with sigmoidoscopy, but then the surgery that would be done in this case would be sigmoid colectomy with a primary anastomosis. The bottom line is blood supply of this, the more longer the blood supply gets compromised, there is more chances of patient going into an unstable pattern for sigmoid volvulus. So these are all features of acute abdomen. All cases of acute abdomen that I've discussed, the diagnosis is hollow viscous perforation, adhesions and bands, malignancy, or sigmoid volvulus involving the large bowel, and most of the time sigmoid volvulus would be geriatric age patient only. Also remember that the rotation that occurs here is anti-clockwise as compared to like cecal volvulus, which would be a clockwise rotation. I'll write this also, the anti-clockwise movement is occurring here in contrast to the clockwise that occurs in a cecum volvulus.